For most women, birth is a normal process free of major complications. However, complications sometimes make childbearing hazardous for the woman or her baby. The nurse's challenge is to identify the complications promptly and provide effective care for such mothers. The complications addressed in this lecture are often interrelated. For example, dysfunctional labor is likely to be prolonged and the woman is more vulnerable to infection, psychological distress, and fetal compromise. Normal labor is characterized by process. Dysfunctional labor is one that does not result in normal progress of cervical effacement, dilation, and fetal descent. Dystocia is a general term that describes any difficult labor or birth. A dysfunctional labor may result from problems with the powers of labor, the passage, or the psyche, or even a combination. What are the problems of power? The powers of labor may not be adequate to expel the fetus because of ineffective contractions. Effective uterine activity is characterized by coordinated contractions that are strong and numerous enough to propel the fetus past the resistance of the woman's bony pelvis and soft tissues. Two patterns of ineffective uterine contractions are hypertonic and hypotonic. Hypotonic contractions are coordinated, but they're too weak to be effective. They are infrequent and brief. Hypotonic dysfunction or secondary arrest usually occurs during the active phase of labor, which is between 4 and 7 centimeters. Management depends on the cause. Many women respond to simple measures. Increasing IV fluids, maybe changing her positioning upright to favor fetal descent. However, additional interventions that could be done or procedures are an amniotomy, which is a breaking of the waters, to help stimulate labor along. This would drop the baby onto the cervix. A complication of that, though, is umbilical cord prolapse and infection. Or we may also augment contractions by using oxytocin. However, we can go the opposite way and have excessive uterine contractions as a potential side effect of using oxytocin to augment labor. Hypertonic is where a woman has uncoordinated and erratic contractions that exceed an acceptable duration or frequency. Very important point. Remember that contractions should not last longer than 90 seconds, and you need a rest period of a minimum of 30 seconds, because every time the woman has a contraction, blood flow goes to the uterus. And if it's going to the uterus, it is not going to the placenta and the fetus. So if we have it longer than 90 seconds, that's like that fetus is holding its breath. Then we need at least 30 seconds to allow enough blood to at least pool and be able to be absorbed or diffused over into the placental circulation. Hypertonic, two terms that we use is hyperstimulation and hypertonus. Hypertonus meaning that the contraction is staying longer than 90 seconds. Hyperstimulation means they are coming so frequently, usually that's more than 6 and 10 minutes, that we can't get enough of that rest period. Both of those require an intervention. If the woman's on Pitocin, we have to stop the Pitocin or oxytocin. And we have to then, we can stop the Pitocin, bolus the fluids, turn her to her left side, and provide oxygen, 10 liters. What is ineffective maternal pushing? A reflexive urge to push with contraction usually occurs at the fetal presenting part as it reaches the pelvic floor during the second stage of labor. It could be psychological, it could be maternal exhaustion, or as a result of having analgesia like an epidural, it suppresses her ability or urge to want to push. What is the management on? combating ineffective maternal pushing. If maternal and fetal vital signs are normal, no maximum allowable duration for the second stage of labor exists. Nursing care to promote effective pushing helps the mother make each effort more productive. Upright positioning is something that we can do, or she may do better in a side-lying position. Also, we help her count through when the labor begins or a contraction begins to count to 10 and aid her in her pushing efforts. What are problems with the passenger? The passenger is the fetus, and the main things we see is problems with fetal size, presentation, or if there's multiple fetuses, or any fetal anomalies. Macrosomia, which is a term used for infants weighing more than 8 pounds or 13 ounces. The head or shoulders may not be able to adapt to the pelvis if we have a large infant. Size is relative, however, to the shape of her pelvis. The woman with a large pelvis may easily give birth to an infant that weighs more than 4,000 grams. However, if her fetus is small, then she may not be able to accommodate such a size. Shoulder dystocia. Delayed or difficult birth of the shoulder may occur, and we'll go over that on the next slide. Also, abnormal fetal presentation or position. An unfavorable fetal presentation or position may interfere with cervical dilation or fetal descent. Remember, we went over the different positions of the head, and if the baby has a poor attitude, and we may have a face presentation or a brow presentation, that has a larger diameter and it will not mold as well. Multifetal pregnancy. Multifetal pregnancy may result in dysfunctional labor because of uterine overdistension. That, when you have a very large uterus, it can contribute to hypotonic dysfunction. Plus, the potential for fetal hypoxia during labor is greater because the mother must supply oxygen to more than one fetus. She is also at great risk for a postpartum hemorrhage because that large uterus has to contract down, and it has to work a lot harder than a uterus that may be of normal postpartum size. Fetal anomalies. Fetal anomalies such as hydrocephalus, which would expand the fetal skull, may prevent normal descent of the fetus. Abnormal presentations such as breech or transverse lie also are associated with fetal anomalies, and these are usually discovered on ultrasound. Now going to a little more detail on shoulder dystocia. Shoulder dystocia occurs when, after delivery of the fetal head, the baby's anterior shoulder gets stuck behind the mother's pubic bone, and if this happens, the remainder of the baby does not follow the head, and we can get some complications with that, such as brachial plexus palsy. That's like an impingement of the nerve. And how we assess that usually is the newborn will not have a symmetrical Moro reflex or startle reflex. They can have a clavicle fracture. It can even result in fetal death. And fetal hypoxia with or without permanent neurologic damage. And you can also fracture the humerus. Our other complications of having shoulder dystocia, which usually comes with a large fetus, postpartum hemorrhage, a rectovaginal fistula. That is where, from the constant pressure during labor onto the soft tissue area there, you get an actual fistula between the vagina and the rectum, so you can actually have stool go into the vaginal canal and then come out through the vagina is what happens in a rectovaginal fistula. A symphyseal separation with or without transient femoral neuropathy. Third or fourth degree episiotomy or tear. If an episiotomy needs to be done for a very large infant, fourth degree, we'll go over in postpartum, actually goes into the rectal tissue. And you can also have uterine rupture. So how do we address if we suspect shoulder dystocia? A lot of times you pick up on that potential because the infant starts to turtle. As the head starts to come out, it pulls back like a turtle does in its shell. So you would call for help because you do not want to leave the mother. Consider an episiotomy. We would do the McRoberts maneuver where the legs are pulled back, suprapubic pressure, and then the physician might do, or the healthcare provider, such as a midwife, an internal rotation. They would remove the posterior arm forward and then roll the patient over. Is another thing you can do to change positioning. That's the mother. And let's see this. Here's a review of shoulder dystocia. These are our landmarks. Notice where the symphysis pubis is. Early in the delivery, the mother's legs are placed in stirrups in the McRoberts position. So we pull her legs way back. An episiotomy is made. The baby's shoulders becomes impacted on the bone while the contractions continue to push the head forward, stretching and damaging the nerves. Now that's the turtling effect. We have brachial plexus stretch injury right there between the neck and the shoulder area. And as I stated, retraction of the head noted, consistent with turtle sign. Shoulder dystocia expected. The legs are pulled back even further. The nurse would provide suprapubic pressure, which is like we're bouncing the shoulder to try to get it to squeeze under. And then gentle traction to determine if the shoulder is lodged under the bone. So then the healthcare provider attempts to realign or rotate the infant, try to get that shoulder to turn over. So now they're working with the posterior shoulder. And as we do suprapubic pressure, they pop the shoulder out and have delivery. Breech delivery. That is when the fetus is sacrum first. And the risk factor with a breech delivery is, first of all, a prolapse cord. And because the largest part of the body is not presenting, and if it's up high or floating, the cord with the breaking of the water might become prolapse. And we may also have fetal head engagement. Head entrapment occurs when the smaller body of the fetus passes through the cervix before it is completely dilated, leaving the large fetal head trapped behind an incomplete dilated cervix. So now you have an entrapped head. This can be a big problem since the umbilical cord is usually occluded at this point by the head wedged in. So we have a double whammy here. We also will have an internal occult prolapse cord. Now these are the different type of breeches which we went over in the processes of labor. The frank breech is the one that is the safest to deliver because we have a large area here So once it becomes engaged and delivered, we don't have to worry about the cord coming through or this part of the body slipping through before the head. In fact, this area is a little larger maybe than the head. The one that is the most dangerous is the footling breech, because this is where the feet could fall through and the head becoming entrapped, because they will fit through the cervix before we're 10 centimeters. And this is even worse with a preterm infant, because they have very scrawny bodies, very big head, and it's more likely to happen. At the end of this lecture, we will see a video of a live breech delivery. So please hang on and make sure you watch it. Breech delivery is more likely to occur the more premature the fetus. Young fetuses tend to have large heads in proportion to their torsos, as I had mentioned, and this can occur with the footling breech. Piper forceps is the forceps that we use. A frank breech is best for attempted vaginal delivery, which I had just explained. And those are the Piper forceps on how they would be used. So what are problems of the passage? That would be dysfunctional labor as a result of variations in the maternal bony pelvis or soft tissue problems. If they have a small pelvis, they'll have slow fetal descent and a long labor. The danger of uterine rupture is greatest with thinning of the lower uterine segment, especially if the contractions are strong. And we went over the four under the processes, the four pelvic shapes. So if she has one of the two, that the platypeloid or the android, then she is more likely to run into problems, especially if her fetus is more on the larger side. Soft tissue obstructions, a couple things. One might be bladder distension. A full bladder impedes descent of the fetus, and that's even more so if they're on an epidural or spinal, because they can't feel their bladder getting full, or even the stress of labor. So we make sure she empties her bladder every couple hours, and a lot of times if they are on an epidural, a lot of facilities will have policies that a catheter be in place. Now, another type of soft tissue destruction, and this is something I've had in the clinical setting. Remember in Women's Health we went over the HPV warts, but not the ones that cause cancer, but the big cauliflower type. Well, a patient can have a full canal of them by the time she delivers. Those warts really feed off of hormones. And I had a patient that had her whole canal filled with them, and the healthcare provider said, you know, in a few weeks they'll really start to recede because her hormones will be coming down, but she could, of course, not be able to deliver vaginally for that reason. Problems of the psyche. Labor is a stressful event. They can have a perceived threat caused by pain. They also could be really tired, and that could affect their psyche as far as a delivery. And also, I had a story. I had this young girl. She was 13. She was from South America, and she was raped in South America. So she came in, and the mother thought she was in labor. And when the doctor went to go examine her, the girl just locked her knees and was screaming. And that's a psyche. Here she is. She went through a very stressful rape. And now she's, of course, being a young girl also, she was going to let a physician, a male physician, touch her. So she obviously, we had to set up for a C-section, but that had to do with her psyche. Abnormal labor duration. We can have a prolonged labor. Remember, think of a rubber band. You keep stretching and stretching and stretching. It starts getting very flaccid in a way. It doesn't have its resilience anymore. Same with the uterus. If you stretch a long labor, or just working out, if you worked out all day, your muscles just aren't very strong the next day. It's very painful and weak. Same with labors, and the problem with that is, of course, postpartum hemorrhage if you wear out the labor, or you wear out the uterus with the stress of labor, a long labor. Prolonged labor, one of the things we look at in deciding rate of labor is, and we went over processes of labor, when we reach the active phase, we expect a minimum of a 1.2 centimeter dilation in a nullipara. Remember, review your terms. And in a multipara, a minimum of a 1.5. The fetal presenting part is expected to descend about 1 centimeter per hour, so that means going through the stations, starting off as negative. Remember, 0 is engagement, very important point. Above that is negative, so the fetus is floating, and then it works down the canal. So if we have a prolonged labor, when we went over hypotonic, then we can augment it with some oxytocin, pitocin, or break the water if the water hasn't been broken. Precipitous labor is one that occurs within 3 hours of onset. Intense contractions begin abruptly. Precipitate labor is not the same as a precipitous birth. A precipitous birth occurs after labor of any length. That means the baby delivers really quickly. However, a woman in a precipitate labor may also have such a precipitous birth. If the physician or nurse or midwife will not arrive in time for the baby's birth, the nurse should wear gloves and deliver the baby. The mother or the fetus may be affected by several conditions in a precipitous labor, such as maternal cocaine use, if the baby has meconium, if she has abruptio placentae. These are all things that a nurse has to think of very quickly if she's going to manage an unexpected birth before the healthcare provider comes on. Now, the fetus may suffer direct trauma, such as intracranial hemorrhage or nerve damage, because of intense contractions with short relaxation period. Priority nursing care of the woman in a precipitous labor includes promoting fetal oxygenation. Remember our interventions for fetal oxygenation, or sometimes they use the term fetal resuscitation. It's what we do when they have those late decels. We're going to bolus fluids, put her on our side-lying position, get her off the vena cava, and give her 10 liters of oxygen. And if it comes on quickly and she was started on pitocin, we're going to stop the pitocin. Okay, premature rupture of membranes. Rupture of the amniotic sac before onset of true labor is called premature rupture of membranes. There are several conditions that can do that. That includes infections such as group B strep or any of our STDs. Chorioamnitis is, which is where it goes right up into the sac, is also caused by STDs and group B strep. If the amniotic sac has a weak structure, if there's any fetal abnormalities, and if she has an incompetent cervix, we may have this happen. Sometimes we've seen this happen during recent sexual intercourse also. What are the complications? Well, both mother and newborn are at risk for infection. Once you break that sac, we hope to deliver the baby within 24 hours unless she is preterm. And so we have to be very careful about our vag exams. The other concern is if it prematurely ruptures, that if the baby's not engaged, she could have a prolapsed cord. Remember, whenever someone comes in with premature rupture of membranes, we have to document the time that the water broke. So if a woman comes in and says, my water broke about 4 hours ago, that's the starting time of the 24 hours. And also one of the things we're worried about is if someone comes in with premature rupture of membranes, are they running a fever? That's one of the things we're going to check. We're going to find out if the water was cloudy. We can ask those questions, any type of odor to it. And very, very important question, have you felt the baby moved recently? Whenever you have an issue of premature rupture of membranes or in a situation that there could be a prolapsed cord, whether it be outside the hospital and the mother coming in or within the hospital, we want to know if that fetus has been moving recently. So what's the management of premature rupture of membranes? Well, it depends on gestational age. If she's near term, we may have to go ahead and do the delivery, but if the fetus is less than 36 weeks or her cervix is not soft or favorable, we got to look at benefits versus risks. Try to get some steroids to mature the baby's lungs if she's premature. So, how do we determine if it's true membrane rupture? A lot of women come in and say, you know, I think my water's broken. It could be urinary continence. It could be loss of the mucus plug. Well, one of the things is when it comes to premature rupture of membranes, we have to be careful on whether we're going to triage with a vag exam. There's 3 times that we do not do vag exams unless we know we have a healthcare provider available or we have an order to do so. One is premature rupture of membranes because you could stimulate labor. Second is preterm labor because we don't want to move it along by stimulating it. And of course, contraindicated, whether a healthcare provider is there or not, is placenta previa. So, how do we determine if it's, again, a true membrane rupture? Well, first thing is we can do a pH check. That's with a nitrazine paper. And if it's more alkaline, then we know that it is probable, because all we're measuring is pH, is rupture of membranes. If she had incontinence, then it would be more acidic. But remember, if she had recent sex, sperm is also alkaline, so it may be a false positive. We would look for pooling through with a speculum, inspecting by the cervix if we see a little pooling there. And then what we could do for positive is we swab some of that fluid onto a slide. It dries, and if we see a fern pattern, then we know it's positive. What are some of our nursing considerations? Oh, the other thing we worry about is if she has been a while maybe with the rupture of the membranes and we know the fetus is okay, they may provide some antibiotics to stop an anticipated infection, or if one exists, if she comes in with a fever, we try to give 2 doses. Also, if she's group B strep positive, we will give 2 doses of most likely ampicillin. And so for nursing considerations, the woman may remain hospitalized until birth. And if she, for any reason, she would go home, which I doubt, the one thing is we're going to put nothing in the vagina, no sexual intercourse. We don't want to risk sending any organisms. They would avoid breast stimulation because that could put her into labor, and frequently take her temperature and maintain activities, and she should be doing fetal kick counts. Preterm labor is labor between 20 and 37 weeks. The physical risks to the mother are no greater than labor at term, but our concern, of course, is the complications of the preterm infant. 1 in 8 babies are now born prematurely. What are our associated factors? A lot of times we don't know, but some possible causes, one of the main ones is a short cervix. That's one of the big ones. If she's had a past preterm infant, STDs, any type of reproductive organ disorder, And another big one is periodontal disease. That has been known, with dental care, any type of periodontal disease is a risk factor for preterm labor. And that's why it's highly recommended that when you're pregnant, and then also Medicaid pays for dental care during pregnancy for that reason, that dental hygiene is kept with and seen by the dentist. What are signs and symptoms of early preterm labor? Well, there may be uterine contractions, but they may not be painful. It's more of a sensation of the baby is balling up. There may be cramps similar to menstrual cramps, and there may be some type of low back pain and pelvic pressure. The pain may also put pressure into the vagina or thighs, or maybe we may also see some increased vaginal discharge, sort of watery spotting or bleeding. She may have some diarrhea. Remember, when a woman goes into labor, she frequently will have diarrhea to clean out the GI tract, so that could be another sign. So how do we prevent preterm labor? Well, first is that we do community education. Preterm birth can impose substantial physical, emotional, and financial burdens on the child, family, and society. Ideally, nursing strategies to prevent preterm birth begin before conception. During pregnancy, we want to make sure that they get good and early prenatal care. We want to assess for risk factors. And we want to teach every patient signs of labor or preterm labor so they have early intervention. We also want to make sure that they have adequate nutrition. So how can we predict preterm labor? Again, looking at risk factors. In one study, the most strongly associated risk factor would be a short cervical length that is less than 1 inch. And that is measured by transvaginal ultrasound. Again, if she's had previous preterm labor, and if we find that they may be at risk, then what we check for is the fetal fibronectin. And the fetal fibronectin is a protein present in the fetal tissues, and it's found in the cervix and vaginal secretions until 16 to 20 weeks of gestation. Then it goes away, and it doesn't come back till she's near term. If it appears too early, it's just that labor may begin early. Now, to reduce the risk of false positive fetal fibronectins, the specimen must be collected before significant vaginal manipulation from the exam. And she should also not have had recent sexual intercourse or bleeding. Infections, STDs, if they've had an STD, they're rescreened later in the 3rd trimester. STDs can do an inflammatory process and cause a woman potentially to go into preterm labor. It also puts them at risk for preterm membrane rupture. So how are we going to identify the preterm labor? First is frequent prenatal visits is the main way that we're going to do that. So suppose we do have someone in preterm labor, how do we stop it? Once the diagnosis of preterm labor is made, management focuses on stopping uterine activity before the point of no return, and that's usually 3 centimeters. Preterm delivery may be inevitable, so we would have to do steroid therapy to promote early fetal lung maturation. We would then identify the cause. We would treat the infection, especially, again, if she's got the STDs. Limit activity. She would be put on bed rest. There would be restrictions on sexual activity. And then we would hydrate the woman. Hydration to stop preterm contractions. Would be a possibility. In fact, that's quite common because dehydration can contribute to uterine irritability. And then we have our tocolytics. That's reviewed in labor pharmacology. One of the big ones we use is magnesium sulfate. And MAG has its potential side effects to the mother and the fetus. We can also use calcium antagonists such as Procardia, prostaglandin synthesis inhibitors such as indomethacin. Instead of going in these in details, just review the labor pharmacology lecture. And again, we have to accelerate fetal lung maturity. That's done over 24 hours. We can either give bechamethasone, 12 milligrams, 2 doses, 24 hours apart, or dexamethasone, which is 4 doses, 12 hours apart. Again, cervical length during prenatal care, particularly at 24 to 28 weeks gestation, has been demonstrated to be the most sensitive prenatal predictor of preterm birth between both high and low risk women, and 25 is approximately an inch. Fetal fibronectin, in review again, is a basement membrane protein that helps bind placental membranes to the decidua. It cannot be detected between 24 and 34 weeks. And we get it by cotton swab, and again, we got to make sure that she's had no recent sexual activity or bleeding or a lot of manipulation. So the sensitivity of the test is good. While a negative fibronectin is helpful in predicting women who are not destined to deliver preterm, a positive one has limited value in predicting women who will deliver. So we're great for knowing who will not deliver. But just because someone's positive doesn't mean they'll absolutely go preterm. And the fetal fibronectin has a predictive value in identifying patients who will or will not deliver within the next 2 weeks. Okay, prolonged labor. A prolonged labor is one that lasts longer than 42 weeks. Remember that the placenta is meant to only last so long. A lot of times if we go past 40 weeks, and even past 42, it's a question of dating. Was the early estimation of due date accurate? And if it is, then our concern is, again, the placenta is meant to last so long, so then it starts losing its function, and one of those is making amniotic fluid. So the main physical risk in prolonged pregnancy is to the fetus. Insufficiency of the placental function secondary to aging reduces transfer of oxygen and nutrients to the fetus and removal of waste, because the fetus with placental insufficiency has less reserve to tolerate uterine contractions. We can see signs of fetal compromise. And also a reduced amniotic fluid volume, that's known as oligohydramnios, often accompanies placental insufficiency and can result in umbilical cord compression. And as a result of that stress, we may have meconium released, which could also put the newborn into respiratory distress. Now remember, many postpartum fetuses don't suffer from placental insufficiency. However, the other complication then may be that we'll have too large of a fetus to deliver vaginally. Therapeutic management. If the woman has no prenatal care or only receives late pregnancy care, we got to make sure that her gestational dating is as accurate as possible. Another factor in managing decisions is whether the fetus is thriving in the uterus, and the main thing we'll do, because we're worried about cord compression and amniotic fluid, is a biophysical profile, because we do get amniotic fluid measures in there. And then if the gestation appears to be truly postpartum and there's no fetal urgency to deliver, we may just first decide if the cervix is favorable for induction, or do we have to do cervical ripening, and that's also reviewed in labor pharmacology. What are our nursing considerations? Well, we got to teach her about the procedures and provide nursing care related to the procedures of induction, the use of oxytocin. Next is our intrapartum emergencies. We may have placental abnormalities. Placenta previa is sometimes associated with an abnormally adherent placenta, known as placenta accreta. And the person at highest risk is someone who's had prior uterine surgery, because you got scar tissue there. Placenta accreta may cause immediate intrapartum hemorrhage, and that's because the placenta does not separate cleanly after birth, or does not separate at all, or leave small fragments. More extreme degrees of abnormal adherence is placenta increta, which it actually goes into the uterine muscle wall, and placenta praecreta, where it goes all the way through the uterus. And I've only had one patient with this, and she did have a hysterectomy. She delivered her child, and then she kept bleeding so bad they had to do an emergency C-section. I mean, not C-section, but emergency hysterectomy, and she had to recover in ICU. And that's usually what happens. A hysterectomy may be required for a large portion if the placenta is abnormally adherent. Prolapse umbilical cord. A prolapse cord is one that lies beyond the presenting part. And again, I'm going to keep stressing the importance of station 0 engagement. If it's above that, then there's always that risk involved. A prolapsed umbilical cord slips downward after the membrane rupture, subjecting it to compression between the fetus and the pelvis. It may slip down immediately with the fluid gush or long after the membrane's rupture. An interruption of the blood flow through the cord interferes with fetal oxygenation. Now, there are 3 variations of prolapse cord. We have an occult, which is the hidden form. It's near the girdle, but you can't feel it if you do a vag exam. It can be right in front of the fetal head. It cannot be seen, but if you do a vag exam, you feel this palpable mass, or it could come out through the cervix. What are our risk factors? The fetal presenting part is at a high station. The fetus that poorly fits into the pelvis because the pelvis is too small. And if you have excessive amniotic fluid, because then you have a much more water and gush and force behind it to have the cord go with the ruptured membranes if you have so much fluid. It's like the difference between a little wave in the ocean and a big wave in the ocean. That big wave hits you hard. Same with this. It drags that cord out. So what would we do? Several ways to manage it. Remember, call for help is always first, and the priority is to get pressure off the cord. If you're doing a vag exam and you feel that pulsating mass, you could lift the head up. You could put her in a knee-chest position. This is the knee-chest position. And it helps the weight of the baby drop off the cord. Or suppose that she has an epidural. Then she may not be able to actually stand on her knees, so you may have to use pillows to prop her, and then maybe put her in a Trendelenburg position. Okay, before we go on, let me finish up with that. What are the signs of prolapse? Signs of prolapse, of course, we went over that when we went over learning about D cells. We would see on our fetal heart rate severe variable D cells, or you may actually feel the pulsation of the cord on a vag exam. Another sign, if it gets really bad, is that the baby starts to become bradycardic. So again, in therapeutic management, we want to position the woman's hips higher than the head. While preparing for surgery, we can provide O2 to improve oxygen saturation. And if she was in contractions and we want to, while we're setting up for an emergency C-section, we may want to give a tocolytic to slow down the contractions so we have better perfusion to the placenta. Okay, going on to uterine ruptures. Sometimes a tear in the wall of the uterus occurs because the uterus cannot withstand the pressure against it. Uterine rupture may occur at home rather than the hospital. And there are three variations. One is a complete rupture, a direct communication between the uterus and the peritoneal cavity. Remember, there are 3 layers of muscle in the uterus. There are 3 layers. So complete means you have gone all the way through. An incomplete rupture is a rupture into the peritoneum covering the uterus or into the broad ligament, but not into the actual peritoneal cavity. And dehiscence is a partial separation of an old uterine scar. Little or no bleeding may occur, and there's no signs or symptoms may exist. And the rupture window may be found incidentally during a subsequent cesarean birth or other abdominal surgery. I will tell you, dehiscence or windows, that's what we say when someone has a window, where they can kind of see through. Where I have seen as a nurse this most frequently, women who have multiple C-sections. You know, they don't recommend more than 3, and if we have someone coming in with a 4th, 5th pregnancy, and they were all C-sections, remember that once you cut into the integrity of the tissue, with a C-section, you have scar tissue. So when you come in again, they got to cut out that piece and then pull it together. You come in again, cut out that piece of scar tissue when you deliver, and sew it up. So you're taking away, and it just makes it thinner and thinner because you keep recutting that area that they start to separate in, like I said, a window. Okay, let me go back to that and finish. And causes, again, is when they've had multiple uterine surgeries or C-section or even surgery to remove fibers. The risk for rupture in a woman who has had a prior C-section depends on the type of uterine incision. If she had the classical, and they're the ones that can never have a VBAC, they are at the greatest risk. Then those with a low transverse. And a VBAC stands for vaginal birth after C-section. Only a low transverse can actually have that procedure. Rupture of the unscarred uterus is more likely for women of high parity, which means they've had lots of children, due to a thin uterine wall. What are the signs of labor? Dehiscence does not have symptoms initially, and it may not interfere with labor or vaginal delivery if the area is small. But if they have a larger area of dehiscence, then they might have pain persisting beyond any analgesia that we give them. So with the uterine rupture, possible signs is abdominal pain and tenderness. The woman might describe the pain as a ripping pain. She may have chest pain between the scapula with inspiration or pain on inspiration, and that's the same sign that we have for those ruptured ectopic pregnancies, because there is irritation of blood below the woman's diaphragm. So placenta abruptio, ectopic pregnancy, we're having that referred pain to the shoulder. and pain with inspiration. Hypovolemic shock, of course, if she's bleeding, when she starts to rupture. And we know all the signs of a shock. That would be tachycardia, tachypnea, falling blood pressure, pallor. And remember what I told you. Changes in vital signs in women, particularly the blood pressure if they're pregnant, is a late sign of hemorrhage because she carries a lot more blood volume. An early sign you are more likely to see in the fetus itself, starting with late D cells. If it's starting to rupture, then it's separating from the placental wall. So we're going to see impaired fetal oxygenation with late D cells, reduced variability, tachycardia first for compensation, and then we'll start becoming bradycardic. We'll have absent fetal heart sounds because the fluid's leaking out, right? So, and we have a large disruption of the placenta, so we may not even pick up fetal heart sounds. And sensation of uterine contractions. If it's ruptured, then we're not going to get that squeezing and relaxation. So we're going to see an absence of contractions on the monitor. And if we actually feel the fetus outside the uterus through the abdominal wall. And if you do, that is usually a large complete rupture, and more likely the fetus is dead. If the rupture is incomplete, blood loss is a little slower. Shock and pain might develop more slowly. The fetus often dies in complete rupture because the placental blood flow is disrupted. And again, an incomplete rupture will take a little bit more time. For nursing, what we need to do is look at risk factors. Who is at risk for having a uterine rupture? Our initial management is to stabilize the woman in the fetus and perform a C-section. So we're going to provide a lot of fluids to make up for that fluid volume loss. We're going to stop uterine stimulation. Remember that bleeding may be concealed if the ruptured area bleeds into the broad ligament. So in that case, those signs of hypovolemic shock are more likely to develop quickly. So we're going to try to do fluid volume replacement, do frequent vital signs, continue to monitor response to our intervention. So if we're providing fluids, is her vital signs becoming stable? Monitor the fetus continuously. And remember, one of the big measures on how successful we are with providing fluid replacement is intake and output. So we're going to make sure she has a catheter. Another emergency is uterine inversion. That's when the uterus goes from the inside out. And the most common time we're going to see something like that is someone starts pulling on the umbilical cord before the placenta detaches, and that's what you're going to do is flip the uterus inside out. That's why they say don't pull on it. And if we do fundal pressure during birth, so this baby's being born and we're going not suprapubic pressure like on the shoulder dystocia, but at the top of the fundus, we start pushing down while the baby's being born, then we could just push it through and flip it out. So what do we do with that? Well, first of all, she's going to have massive hemorrhage, pain, and shock. And we have to quickly replace the fluids. The physician or healthcare provider will try to replace the uterus through the vagina into a normal position. And of course, if the uterus is contracted, we're going to have to relax it. So we're going to have to give her some maybe mag or a tocolytic to relax it so it easily can be flipped back. We're going to provide blood replacement, fluid replacement, and a hysterectomy may be required. Now, an anaphylactoid syndrome, that is also known as amniotic fluid embolism, and that's when amniotic fluid is drawn into maternal circulation and is carried to the woman's lungs. Fetal particulate matter, such as skin cells and vernix and hair, in the fluid obstructs pulmonary vessels. Failure of the right ventricle occurs early and can lead to hypoxemia. She will have abrupt respiratory distress, just like a pulmonary embolism, and decreased cardiac function and circulatory collapse. Now, she may also go into DIC with this condition. So, how are we going to handle that? Think of anyone that's going to possibly have a pulmonary embolism. We're going to do cardiopulmonary resuscitation and support, provide oxygen and mechanical ventilation. We're going to correct the hypotension. And if we have to provide blood, then we will provide blood. Trauma. Remember, when we have trauma, the nursing care of the pregnant trauma victim focuses first on maternal and then fetal stabilization. Remember, be careful when you answer questions that if it's the mom that's distressed, your intervention is going to address her first. A lot of the interventions that we do are for the fetus. So if mom's blood pressure is low, she may be okay for a little bit, but it's the fetus is the priority because they're more sensitive to that. But if mom's having a pulmonary embolism, not breathing, coughing up blood or something, you don't pick an answer where, okay, check the fetal heart tones or something like that, because you got to stabilize the mom first because she's the one who's in distress. And that is I've seen a common issue with students answering questions. They're so focused. We keep telling you how important it is about monitoring the fetus. Whenever they see monitoring the fetus, they want to answer that right away. But first remember, we have two patients. Which patient are we dealing with? And remember, whatever intervention you do affects the other patient. We also, if mom is O negative, negative, RH factor negative, and she's involved in any type of car accident, trauma, there's always the risk that her blood may intermix with the fetus. So we always do a Klein-Hauer-Betke test. And to assess that. It's ordered at intervals to identify placental disruption that allow fetal blood to leak into circulation. So, and that's for any mother, but if she is negative, and of course we're going to give her a RhoGAM with that, and that will at least tell us also if we have any fetal blood in her circulation. One of the main things we worry about if she's involved in trauma, of course, is injury to the fetus. And we're going to also worry, other things that could happen is placenta abruptio. We want to make sure there's not enough trauma that she wants to release her clotting factors that can put her into DIC. In fact, motor vehicle accidents are the leading cause of blunt trauma during pregnancy. So once the woman's condition is stable, nursing care intensifies for the fetus, external monitoring is appropriate, and preterm labor may occur but may not be recognized if the woman is unconscious or in pain from the injuries. Okay, and this is that breech delivery I was talking about.
section places the baby at risk by the time they are delivery, and the mother at increased risk of cesarean section presentation places the baby at review of randomized trials, and the mother at increased risk of cesarean section. Systematic review of randomized trials shows that the chance of breech presentation at birth may be reduced by attempting external cephalic version. For persistent breech presentation, the option of delivery of cesarean section or vaginal breech delivery. Systematic review shows that planned cesarean section prevents about 1 perinatal death for every 100 deliveries. In some situations, the risks to the baby of vaginal birth are outweighed by the current and future risks to the mother of cesarean section, or cesarean section is not feasible.
Don't worry, we're getting it.
Delivery are cesarean section or vaginal breech delivery. Systematic review shows that planned cesarean section prevents about 1 perinatal death for every 100 deliveries. In some situations, the risks to the baby of vaginal birth are outweighed by the current and future risks to the mother of cesarean section, or cesarean section is not feasible. It is thus important for health workers who care for women in labour to be skilled in breech delivery techniques. Favourable factors for vaginal breech delivery are shown here. If labour does not progress well or the buttocks do not deliver easily, it is preferable to opt for cesarean section. The techniques of vaginal breech delivery shown in this program have evolved from clinical experience, not randomized trials. The delivery position used in the cases which follow is with the mother sitting propped up at 45 degrees with a backrest, or resting on the thighs of an assistant kneeling on the bed, and her legs in lithotomy stirrups. She has an intravenous infusion in place, and her bladder has been emptied. An assistant encourages her to bear down effectively. It is most important that the baby be expelled by effective bearing down efforts. Any traction from below tends to cause an extension of the arms and head. An episiotomy may be cut as the buttocks distend the perineum. Only after the buttocks have delivered easily and spontaneously, and the decision is taken to continue with the vaginal delivery, commence an oxytocin infusion to assist uterine contractions. As long as the delivery progresses spontaneously, resist the temptation to pull the baby down, up to the point that the shoulders have delivered. Once the baby's head is engaged in the pelvis and the hairline is visible, control the delivery of the head with a method such as the Morisot-Smellie-Veit method. With the baby straddling your right forearm, position the third finger in the baby's mouth and the second and fourth fingers on the malar bones. Place the second and fourth fingers of the left hand over the shoulders and the third finger against the occiput to maintain flexion while the head is carefully delivered. The second breech delivery shown here is more complicated. The extension of one of the baby's legs is an unfavorable factor. In the case of a frank breech presentation, splinting of the baby's body by both legs may prevent progress. In such a case, deliver the legs by gently flexing at the knees. When the umbilical cord appears, pull down a small loop to prevent traction on the cord later in the delivery. The baby's back will usually rotate anteriorly. If it is tending to rotate posteriorly, hold the baby with a towel around the pelvis, not shown here, and gently turn the baby so that the back faces anteriorly.
Notice the meconium.
If the shoulders do not deliver spontaneously, despite effective bearing down efforts, their delivery may be assisted by various maneuvers. The anterior arm may be delivered by passing two fingers over the baby's back, along the humerus to the elbow, and sweeping the arm around in front of the baby's face and chest. One or both of the shoulders may be delivered by the Loveset maneuver. Hold the baby by the pelvis with a towel, not shown here. Rotate the baby through 180 degrees back uppermost, so that the posterior shoulder appears below the symphysis pubis to be swept down over the baby's face and chest. If the baby cannot be rotated, posterior shoulder may be delivered by lifting the baby upward, chest towards the mother's thigh, passing 2 fingers up the baby's back, and sweeping the posterior arm over the baby's face and chest. Once the arms have delivered, encourage the mother to bear down until the baby's neck and hairline appear, indicating that the head is engaged in the pelvis. If the head does not engage, the Morisot-Smellie-Veit method may be used to push the head up slightly, rotate to the oblique diameter, flex it, and pull down. Suprapubic pressure may be used to assist flexion and descent of the head. Here, the baby's head is delivered by the Morisot-Smellie-Veit method, as described before. An assistant may support the perineum. The second breech delivery shown, though difficult, took 4 minutes, and the baby was in excellent condition after birth. An alternative method of delivering the head is the Burns-Marshall method. Once the head is engaged and the hairline is visible, hold the baby by the ankles with your left hand and swing the baby through an arc up to a vertical position and then over the mother's abdomen. Support the perineum with your right hand as the face delivers. For forceps delivery, hold the baby by the ankles and swing to the 45-degree or vertical position where they are held up by an assistant. Use long curved forceps or Piper's forceps. Fit the forceps handles together with the pelvic curve uppermost. Hold the left handle vertically with the left hand fingers as one would a pen. Insert your lubricated right hand posterolaterally into the vagina. Guide the forceps blade with the fingers of the internal hand to lie alongside the baby's head. Apply the right blade in the same fashion, using your left hand to guide it into position. Confirm the correct positioning by the fact that the handles lock together easily and the baby's face is symmetrically positioned between the forceps blades. Deliver the head by steady traction on the handles and downward pressure with the left hand on the shanks of the forceps so that the resultant pull follows the curve of the pelvis. If the head cannot be delivered, consider rapid caesarean section or symphysiotomy. For symphysiotomy, infiltrate the skin and subcutaneous tissues overlying the symphysis pubis with local anesthetic. 2 assistants support the mother's legs to prevent unnecessary separation of the pelvic bones. Pass a firm plastic catheter through the urethra. Insert the index finger of your left hand into the vagina along the urethra and move the urethra away from the midline. Make a small vertical scalpel incision above the lower part of the symphysis pubis. Angle the blade toward the top of the symphysis pubis. Cut the anterior fibers of the symphysis pubis with a sawing action from the top to the bottom of the joint, keeping a thin layer of the innermost fibers intact. Deliver the head by the Morisot-Smellie-Veit maneuver or with forceps. The symphysis pubis separates just enough to allow passage of the baby's head. It is useful to routinely have a local anesthetic, a scalpel, and a urinary catheter available during breech delivery in case an emergency symphysiotomy is needed. Reducing perinatal mortality depends on the presence of a skilled attendant at birth.